You've heard all of the complementary talks about treatment, about the different paradigms in treatment, but surgery is a component of treatment. And the goal for me is to be able to take a tumor out, but not just take it out, to be very aggressive with taking it out, but most importantly is to preserve the quality of life. And I think that has really been a challenge through the years, and it's gotten me into the things that I'm going to talk to you about today. So it doesn't really help to take out a tumor if we are hurting people, but I'm here to say that we have a lot of techniques that we've developed and innovative and use on a daily basis to maximize extent of resection while minimizing morbidity. And I'm going to sort of get into it, but I think it doesn't make any sense to get into this topic to tell you what we're doing in the surgical field without first spending just a few minutes to emphasize what Mark was getting at, which is that extent of resection really does affect outcome. Now, we're not curing patients. That's with surgery alone. We understand that, although there are certain low-grade tumors, like the pilocytic tumors, that we do cure if we're aggressive with surgically. But the point is that we're extending life for these patients if it's good quality of life, and we're giving time to the neuro-oncologists and our research colleagues to develop new cutting-edge innovative therapies, because that's what it is. It's about, and you heard it today, it was very well stated that we need to turn this into a chronic disease. And surgery is part of turning it into a chronic disease. So it's very typical that I'll operate 3-4 times on a patient, and I'll keep doing it as long as their functional status is good and they're ready to do that. And we have another treatment modality to come to them for. So this just shows you that for low-grade gliomas, like what Mark was talking about, if you go back and look at the literature, there's a lot of data out there, including one of the studies, the Smith paper, where we showed that extent of resection does impact outcome and also reduces the risk of malignant transformation for low-grade tumors. So that's clear to us now. This is actually the first study that I ever published that I think got this going, which showed to me for the first time that if you look at 10-year survival, we had a lot of 5-year data, but if you looked at 10-year survival before we knew about molecular markers, we saw a very clear trend that we could take a patient, and even though they might progress, and certainly do that in a 10-year period, that if we did an aggressive resection safely, preserve their quality of life to the greatest degree possible, that we could see survival up to 10 years. That doesn't necessarily mean progression-free survival, but it was the first indication that what we were doing was working. So that's an important advance, and these are some of the statistics associated with extent of resection as well as the volume of residual disease in terms of outcome for low-grade tumors. So we showed that. Now, as time went on, more and more groups around the world began to analyze their data, and I'll just show you this one study, and then I'm going to show you the only really prospective study looked at, but this is the biggest compilation of low-grade gliomas from the French Low-Grade Glioma Consortium, showing, as you can see in the top survival curve, that you can extend overall survival and impact malignant progression-free survival if you can achieve a complete radiographic resection of these tumors. Not always possible, but now I'm going to end the talk with the techniques that we use to try to do this. But I first need to show you that we can make an impact. Now, this was a very interesting study which has changed the course of our thinking as surgeons, because it's really the only comparative prospective study done in a Scandinavian country where if you live in the southern postal codes, you got a resection. If you lived in the northern postal codes, you got a biopsy. And it was that kind of a study that showed in these survival curves that for the patients that were more aggressively treated early on, they did better. They did better in terms of their overall survival as well as their malignant progression-free survival. So now there are really 3 major studies from all of these 3 different countries that show us that we can impact outcome in our patients if we're more aggressive early on. So the concept that I grew up in, which was a wait and see modality, that's what the neurology colleagues used to say to patients when they had a seizure and had a low-grade glioma, that doesn't fit anymore. It's really all about a maximal safe resection, and I think we all appreciate that fact now. The other thing we have to deal with, and Mark pointed it out, I think, a little bit, has to do with symptom management. And, we put our patients on anti-epileptic drugs. They're young patients, and they're impaired by these medications. So if part of our surgical strategy is to reduce the risk of seizures, then we need to keep that in mind. Because, again, it's all about quality of life. So here's a meta-analysis on a study we did looking at the literature, looking at all the factors associated with seizure outcome, and the bottom line is the most important factor tends to be gross total resection of the tumor itself, because most of the seizures come from this main nidus of tumor or the area around it. So that we know if we're aggressive surgically, another benefit is impact on seizures. This is again from the French consortium. French consortium showing that if you can achieve a total resection here, then the likelihood of a seizure-free situation as well as patients on medication who are seizure-free is greater than if you don't achieve a total resection. So we know that this is an added benefit of what we're doing. And I'm not going to go into this too much because Mark covered it so well. But I think what this has done is it's made me rethink as a tumor surgeon what to do for these patients. Because it used to be that if I had a patient who was 53 and I did a gross total resection, that I felt that they were low risk. Well, according to this study, they're high risk. The same as a patient who's 23, where I only did a 95% resection. Now, again, we don't know the markers, and Mark pointed this out. But if you forget the markers, now that patient's high risk. And that's opposite of what I believed before this study came out. So we have to rethink this because these survival curves are showing us that there's a different way to think about risk stratification. And so now it's truly only those patients who are under 40 who I do a complete radiographic resection that I say, okay, we can sit tight and not do anything. But everybody else is up for grabs because of this data. It's so convincing that it seems to me we have to start thinking about treating patients more aggressively early on. Now, when the molecular data comes out, I think we may have a different insight into the disease, but we'll have to wait and see. As far as the high-grade gliomas are concerned, basically, I think the paradigm started to shift around the year 2000 when this article came out from MD Anderson where they said, look, if you can do a 98+% resection, you're going to make an impact on your patients. Well, that never sat very well with me because I'd operated on a lot of patients. I did a 70% resection, 80% resection, and there's no question that they improved in terms of not just the quality of life, but their overall outcome. So I really didn't like that. That troubled me. Although I understood it was a really good study, and they now have sort of gone back and looked at their data and showed that, sure enough, as you'll see on the next slide from a study that I published, that you get a benefit, an added graded benefit all along that extent of resection curve. Now, again, I understand we're not curing patients, but this is a paradigm shift from that 98% mindset. And what it's done is it's told neurosurgeons around the world to stop thinking about just a 98% resection. In other words, you go into the operation, you do the aggressive resection as safely as you can. And if you can get that resection much above 50%, 60%, 70%, you're going to get a graded advantage in outcome of those patients. You already heard the immunotherapy research talks tell you that there may be an advantage to immunotherapy if they're starting with the least amount of residual disease. So it's our responsibility to create that. This is my work looking at 500 newly diagnosed glioblastomas that we published, showing a few years ago that, again, extent of resection, it wasn't just the 98% cutoff, it was much higher than that. In fact, the data started to look significant once we got much over the 78th percentile. So again, from my point of view, I go into the operation, even if I know I may not get a 98% resection, I'm going to be as aggressive as I can, because once I get past a certain amount, I'm going to add something on to the benefit of that patient's life, and they're going to get more out of the treatments that our neuro-oncologists are now going to put them on. This was kind of a sentinel event for us as surgeons, this whole business about ALA. In other words, how do we see tumors in the operating room? This is a dye compound that gets incorporated into the porphyrin pathway. And under a fluorescent light, you can see, it's difficult to see in this light, but the tumors turn pink or orange, depending on how aggressive they are. And you can get a very nice indicator to show you that you can do a more visible extent of resection. And you can see the survival curves with this compound, which, believe it or not, is still not approved in the United States. The FDA has got their head up their ass, because this is something that everybody should have with a glioblastoma treatment. I carry my own IND to do this with our neuro-oncology group, so I get ALA and I use it, because the FDA is completely wrong on this, and I don't have any clue. It's very safe, other than a rash if you go out into sunlight too early, but you're in the hospital. That's only for 3 days. So this has been a problem, but you can see that if you want to do a gross total resection, you can do it better with ALA than if you don't use ALA. So why not use it? And they looked at their overall survival eventually. This was a randomized study out of Germany, where they did this original study and showed that the overall survival with an ALA-guided resection is much better than a light-guided resection with the standard microscope. Now, you can take this one step further, and this is a study that's come out looking at intraoperative MRI. This is another innovative technique. The problem is, not many of us can have intraoperative MRI in our ORs because it's too expensive, and so that's not really attainable for most centers. But what it shows, again, is it's not just having MRI, it's not just having ALA. The only way that these techniques work for patients is if you can achieve a gross total resection or something above that percentage, meaning 70th percentile on and on. That's when you start to see the curves splitting apart. Now, the next step in this process is to say, okay, if we can take this out, can we go beyond the enhancing area, and can we do better? And this was a study that just came out, again, from the MD Anderson group, which I thought was very provocative, which shows on this next slide that as you increase the extent of resection on the T2 abnormality, now again, remember, you've got tumor cells around the resection cavity, but if you can do even more, then your survivals increase steadily with not just the enhancing portion, but the non-enhancing portion. So this is yet the next step for us, again, as surgeons, to help present a patient to the neuro-oncologists that are going to potentially get the most out of their treatment modalities. So how do you get to this point? Well, you get to this point because you got to do a lot of surgery. You just can't walk into the operating room and do one patient every month. And this is data that we published showing that if you want to do good tumor surgery, you got to do a lot of it. And this shows you on the left, the mortality by surgeon volume goes down as you do more cases. And it also shows you that the discharges, meaning the length of stay, are affected in a positive way as well. And this is complication rates by hospital volume and by surgeon volume. So we're doing better, safer surgery if we're doing more of it. Makes sense, right? If you do something and I won't use the word practice at it, but if you do routinely, you're a better surgeon. I'm a much better surgeon now than I ever was 10 years ago, or even 15 years ago. So to me, it is really about experience, and that's very, very important. And if you don't believe me, look at the data out of the United Kingdom, where most of the patients are not treated with surgery. They're treated with a biopsy because they're in the national health insurance process there. But in those centers that have experienced surgeons who specialize in neuro-oncology, even they show an added survival benefit from those surgeons who do more of it. So there's no question that experience is key. So if you understand that, now I can get to the second part of my talk, which is if I've convinced you that extended resection is important and that we can do better if we do a lot of it, now the question is, how do you do it better? And the way to do it better is to use a technique that identifies function in the patient, in that area of the tumor, maps that function, and then preserves it during the course of surgery. And this is a study that we published in the Journal of Clinical Oncology a few years ago, showing that if you looked at all the surgery that's ever been reported out there, and you look at it being done with mapping to find function versus not mapping, then you see you have a 50% reduction in morbidity. So why not use mapping to improve morbidity? It just doesn't make sense not to do it. In fact, it's really become the standard of care. And yet there are still, I would say, at least half the surgeons in our country alone who don't use it. In fact, I just read a study that was published in the Journal of Neuro-Oncology from the Canadian neurosurgeons. A poll was just done, and it showed for awake craniotomies that less than 20% of patients in Canada get this technique. And it just doesn't make any sense to me, because as you'll see, you not only maximize extended resection, but you minimize morbidity. And here's a good example of how it impacts outcomes. So this was a study we did several years ago, and it was basically a study saying that if you go to the clinic and you see a case of a tumor in an eloquent location, and you go into that operation and you say, I'm not going to do mapping, then what's the difference in survival? That if you say, I'm going to do the mapping, I'm going to spend an extra 30 minutes in the operating room, and if I find function, is that going to make a difference? Well, if you find function and you have to stop, versus if you don't find function and you can keep going. You thought it was in a very important area, but it turns out not all areas in the brain are functional. So now if we do a more aggressive resection, because we didn't find important eloquent tissue, the outcomes, the 5-year overall survival is significantly different. So why wouldn't you want to use this technique? Well, there are reasons for it. But here's the reason why you would want to use it. And this is not the patient, but she looked like this. So I got this picture off the internet just to, but she looked just like this, right? So her husband comes to clinic and he brings his wife in and he says, and he's a physician, right? And she's got a great career. She's brilliant in her own right. And she had one seizure. Now she's got this. And he says to me, well, can you operate on my wife safely and take this tumor out? I said, oh, I don't know, but we can definitely try. And I think that's all I can bring to the table. I can try to operate and remove this tumor. Well, he said, I've taken her all over the country and everybody says it's inoperable. They did all this functional MRI stuff and they told me, oh, it was inoperable. I said, look, I don't know, it may be, but I'm willing to try. Okay, so what am I thinking about? I'm thinking about the fact that she's got 2 young kids, yeah, and that he told me he doesn't want any morbidity under any circumstances. That's all bothering me, of course, and I worry about it, but I'm also thinking about what I'm going to find in this area. There are a lot of important things, pathways, function. What if I hit a blood vessel and cause a stroke? There are all these deep white matter pathways that all connect different regions of the brain, as I'll show you. And if you injure any of those, you're going to cause morbidity. So the bottom line is, in her case, we took her to the operating room, and I'll just tell you the punchline. We didn't find any function, as defined by these numbers, and it gave me an avenue to go into this tumor and to map deeply and to remove it. So I was fortunate in this case. She was fortunate in this case. And even though I created a small area of diffusion-weighted positivity, I wasn't worried about it at the time of surgery because I knew that none of this stuff here was important. Now, if I would have gone back to my textbook from what I learned in medical school, I would have said, oh, wow, the arcuate fasciculus is here. I'm going to get into trouble. But the reality is that is not where her arcuate fasciculus was or her superior longitudinal fasciculus. And she had, knock on wood, no deficits. Now, I've had my fair share of deficits, and I'll show you that. That's not the issue. But the point is, I didn't know preoperatively if I could do this. So why give up on a patient? Aren't we supposed to be their advocate? Yeah, we're supposed to be their advocate. I'm going to go to the OR. I'm going to spend the extra 30 to 60 minutes to do the mapping because I want to do an extensive resection. And to get there, and I put this slide in because this is part of my Seattle roots, George Ogeman. You know, I came to the University of Washington way back when, 1986, and George was doing all this epilepsy stuff, and he wasn't interested in tumors, but he said, you know, you ought to come down and see what I'm doing. And I came down and saw what he was doing, and a light went on in my head, and I said, man, if I can map the brain function in many different ways and realize that there's a great deal of variability in all of us, then maybe I can push the limits of resection. And sure enough, we found out with this very important study, and I won't bore you with the details, but what I found out was there's tremendous individual variability in language function in all of us. There are no two people in this room, I guarantee you, that have the same language pathways. And if I were to say how many of you are bilingual, how many of you are bilingual? Raise your hand. Well, I'm here to tell you that you tend to have more than one location in the brain for the same function. So if I were to show you a picture of a cat and you were to tell me what the cat is in English versus French, it would be in different locations depending on when you learn that language. So sometimes it takes more than an hour because you have to map all these different languages. And in San Francisco, we have a very rich culture and we see all sorts of folks and we do all sorts of different mapping. But this was, for me, this was a mind-altering experience. It taught me that, you know, you just can't predict how a patient's going to do. You gotta go for it, and you gotta see where their function is. And this is a study now, skipping ahead, of a manuscript that's going to come out in the Journal of Neurosurgery, and it just basically takes every case I ever did, all the mapping I've done, it looks at that data, and it basically shows me the variability of function. So for example, if I were to look at the probability of finding function in a given area, say for speech arrest, versus the variability of that function in a given patient, you can see that there's a great deal of variability. It's not always where your textbooks tell you it's going to be. And the same thing exists for naming. Like the probability of finding naming in your brain sits in this area. But it could be variable. It could be all over the place in different locations. And you don't know that until you get in there and map patients. And here's the key. The key is, and I'll show you this from the study that I'm just about to publish, is that there's a tremendous potential for the adult brain to rewire itself. And the longer you have a lesion, a tumor in an area that's said to be functional, not like a glioblastoma, but a long-standing low-grade glioma, the more likely it is that the brain can rewire itself. And I'll prove this to you with a study that I'll show you. So now, skipping ahead to many, many years after I left Seattle, I carried these studies forward, and because I was doing tumor surgery, I was having to do much smaller exposures, more focal mapping than the epilepsy people were doing. And basically I wanted to prove that what I was doing was safe, was still safe. Even though I wasn't always finding a language site in the brain, I really wanted to prove that if I found no mapping positivity, I can act on that negative data like I just showed you in that woman, where I could take the tumor out and not get into trouble. And so these numbers they refer to how often at a given site I would test it in all these patients and how likely it was to find function. And the weird thing is that in the area where you expect to see function around the perisylvian networks, you oftentimes don't find function, especially in these patients that have chronic lesions. So again, points out the likelihood of reorganization. But here's the data in terms of safety, because after all, this is the key. You know, after you do these operations, these patients don't look very good. They got lots of deficits, but as long as you respect the mapping and you leave those functional areas alone, they do much better as time goes on. And the likelihood I can tell a patient when they're in the clinic with me, like I told this woman and her husband, that I'm going to get a permanent deficit, is this number if I can find function and if I can preserve it, both at the cortical and the subcortical level. So we do a lot of awake surgery, and I'll just show you, I think a lot of you are not surgeons, so I'm just going to show you what, this takes like a minute and a half. Well, I'll just show you what it's like for me. I mean, what is a day in the office like? This is a day in the office. We're going to go to the operating room. We're going to take a young, healthy woman like this who's awake. And we're going to do this surgery. And it's not that I didn't invent awake operations. This was before I was born. But the point is, we kind of morphed it. We morphed it to a point where it's practical, it's readily available, and it's safe to do it. And we show people these pictures, and we can show anybody anything. And then we stimulate the brain while they're showing the pictures. And if they're able to respond and give us the correct answer, then we know that site is not important and we can remove it. So recently, and then we do the surgery. And they're awake when we're doing this. They don't feel anything. We're just doing this. And we're mapping as we go, as you'll see. And in fact, recently I operated on a woman who awake, and I said to her, "What's the most important thing in your life for you?" She said, "Playing the guitar." So I said, "Okay, bring your guitar in the operating room." And she played her guitar until I started to see degradation of her praxic movements. And she started to get a little dyspraxic, and the guitar playing slowed down. I said, "That's it." So again, it's a really good technique, and I'll just go forward from here. This is my experience. I recently published it, and it just made me go back over my 27 years of doing awake operations to find out, how I was doing. Is it safe? Is it reliable? And I went back and looked at the literature about all the issues with regard to failure rates in other groups that were doing awake craniotomies. And I found that, and this is based on my experience both at the University of Washington as well as at UCSF, and now my numbers add up to over 1,000 cases of awake glioma cases. So in that whole process, I've developed a lot of ways to do things that I know are safe. And when I started this out, now I'm not going to go into this, but when I started this out, I had a lot of reasons why I was worried about doing these procedures. So for example, when I started doing this, I would stimulate the brain and I would cause a seizure. So I figured out a technique where I could actually irrigate the brain with iced Ringer solutions, stuff that cardiac surgeons use to allow me to stimulate the brain and not cause a seizure. And now, we published this years ago, and now there's a whole movement in the epilepsy world to focally cool the brain. And there are devices that are being invented to focally cool the brain in patients who have intractable seizures. So basically, what do? You troubleshoot. And over the years, this article shows how I got through all these problems. And I'm not going to bore you with this. It's just about the process of, we bring a patient into the room, we put them asleep, we open up, we wake them up, we do the mapping as you saw, and then we put them asleep for the closure. And this is just a little animation that in a few seconds shows you what we do. We test counting for speech, we test naming for name recognition, we test for comprehension, reading, guitar playing, vision, mathematics, whatever you do what you need to do based on the location where you're at. And the anesthesia has changed. I remember the days I was doing this, I didn't even have I had local anesthesia, but nothing else. And the patients just hated it when the bone was coming off. But now they go to sleep. They have the Michael Jackson drug, propofol, or they have dexmedetomidine, and they do really well with that strategy. And so it's all come together now. The technique has evolved. And this is an interesting thing I've learned. And in maybe the 5 minutes I have left, I just want to cover this. Plus, I want to show you one example of a tumor that brings it all home. And so the issue of plasticity, can the brain rewire itself? And this was work that was done by a young surgeon called Hugh Defoe, he was in Paris. He was a fellow with me when I was here at the University of Washington for 3 months, came to learn the mapping techniques, and went on to do great things, and has shown me that plasticity does exist. So for example, here's a tumor in an area. I did a preoperative scan, and I can see the red showing the motor strip and how the tumor sits right in the motor strip. But I didn't say it was inoperable. I told the patient, we'll go in and we'll see what we can do. And you can see all of this is functional. The tumor sits underneath here. I found one little window to go in, and I was able to take it out. And the way it's done awake is you just keep doing it until the patient gets a significant deficit. But I know that the stimulation shows me that the pathways are still intact. So this looked bad in the beginning, but it gets better because I know that the pathways were intact. I found them, I left them alone, and I pushed the resection to the best degree possible. So it's going to get better as long as you know where you are doing this. But here's the point of all this. The point of all this was to say that in my experience, and because I'm now at an age where I've reoperated on many of my patients, I've been able to confirm that reorganization does take place. So for example, here's a case I did, and I found these areas for function, and then I went back 32 months later, and the areas I found that were functional are now gone. So having a chronic lesion in that area resulted in reorganization. And in fact, if you look at this data, it's interesting that in 40% of the cases that I've reoperated on, that there's loss of function, that function actually shifts. So you don't see function moving into the field, function moves out. So now when I see a tumor that's in a functional area, I take out 90%, I leave 10% that's functional, and I tell the patient, we're going to come back in 2 or 3 years. And we'll go back, and oftentimes in up to 40%, you see function has shifted. So again, just to point out, these are my complication rates. They're not zero. I wish they were, but they're never going to be zero. But they're low enough that I feel confident that I can tell patients that the likelihood of a late permanent deficit, something that I cause, is at least 3% or less. And to me, that's important. So it's something that should be the standard of care, whether you're here or in Canada. But the reason you're not going to see it that way is because it takes time to do it. And it takes experience. And a lot of surgeons are just not willing to put that into it. And the other thing is, it takes a knowledge, a certain knowledge. And this is a study that I wrote recently and published in the Journal of Neurosurgery because I wanted to show what we've actually learned, what neurosurgeons should know about the contemporary model of language organization, not just from all those sites I showed you in the studies, but also deep underneath that area, the subcortical pathways. And this is just a review of that. And this will bring it home to you. So this is a case of a tumor, very complicated, in a very difficult area. Now we're going to go ahead and we're going to map that. But during the course of the procedure, as I'm doing the resection, I have to stimulate as I'm going along because I can't see these subcortical pathways. They're going to be in there somewhere. And so this is the technique that we use to just stimulate and look for, while the patient's awake and while I'm resecting the tumor, any deficits. And sure enough, in a case like this, right here, you can see the preoperative tracks that govern language function and connectivity. I found one of those tracks and had to stop at that point. And this is exactly the problem. I had to leave this tumor behind. That's okay. I'm going to come back. If it grows, it'll grow. And I'll come back right at that point at number 37. And hopefully in a few years, it'll be gone and we'll do it. But this just shows you graphically with the tumor in red. I found a phonological paraphasia. I stopped at that point, number 37. And this is a study that's about to come out in print in the Journal of Neurosurgery, showing that we can now use post-operative diffusion tensor imaging to tell us if we've taken out parts of these subcortical tracts that can predict the likelihood of causing a long-term defect. So now I have a way, when I see a patient post-operatively who has a problem, I can do the scan, I can show it to them and their family and say, don't worry, it's going to get better. Or I can say, part of that pathway is out and we're just going to have a deficit, but I don't know how significant it's going to be. So this is a great way to predict that. And this is just, you can't really see these lines, but it's just a point from a paper we just published showing you that, you know, if you do this surgery, you got to have a stomach for it. Because every time you walk into that patient's room post-op and they're not speaking, you got to have the faith based on everything you've done with mapping that it's going to get better. Okay, and then, am I at the limit, Charles? Probably. Huh? Okay, I only have literally 3 minutes because I know Mark Chamberlain will get upset at me if I took more time than him. Okay, so let's take one example of how this all comes back together. Again, this is, to me, the most complex tumor you can do. It's a deep-seated tumor. It's in the insula. It's in the dominant hemisphere. And I'll just show you how we get around this. And we look at it, and Bill Rivas is here, who's probably the world's master at these dissections. And he's running a course this weekend showing this kind of stuff to surgeons to train them. But it just shows you how complicated all this anatomy is. And if we're going to work in these areas, we've got to work down in this region. And it's just one of those things that I've come to realize that you have to be able to think about this three-dimensionally before surgery and to group these tumors into different zones so that you can get a sense when a patient says to you the all-important question, well, how much tumor do you think you can get out? Now, based upon this classification scheme that we've done and published, we can predict how much we can take out. We've also recently published our experience with insular tumors showing that you have a couple of options. And one option is to go through the natural crevice that divides the temporal lobe from the frontal lobe, the Transylvian approach. The other is to actually map the brain and go through the cortex if it's silent. And this just shows you, if we're looking at exposing the insula, that you can always do a better job if you can take off silent cortex to get there. And most importantly, because we use instruments to do these resections, you can get these instruments into these holes better to do a more aggressive resection. And so this is the strategy on this animation that I use, where I would map the cortex. If it's silent, I then take off areas of the cortex, and then I have to work through those arteries that I showed you on the dissection to remove the tumor and then to gradually be able to map the motor and the subcortical language pathways, as I showed you, all during surgery, to get me to maximize the amount I'm removing while minimizing the risk to the patient. So it's kind of like a process that goes on for each operation where you just got to pay attention to all these details. So here's an example of, and I'll kind of run through this because I know time is running out, but if I can show this. So this just shows you what it's like to do one of these operations. You have to work around the veins and you have to split the arachnoid and you have to open it up. And it's not trivial to do this. This part in itself takes about 30 minutes just to get to this point. And then sometimes afterwards, if that exposure splitting the fissure is not good enough, then you have to go transcortical if you've mapped it out and everything's safe. And then to make a long story short, this is what it comes to at the end. So, wow, we've split the fissure, we've gone through silent brain, and we're just chunking this thing out over and over and over until we get as far into this tumor as we can, because these typically occur in young patients. So we want to be aggressive with that. Now, this is a strategy I tried actually 2 days ago using an intraoperative CT scanner. And you'll see one of them here. They've got one in their lab there. And it's a really interesting strategy to try and get an intraoperative scan to show you where you're going at this point. And if we can somehow morph that onto the preoperative MRI scan, which we're trying to do, to show changes in that preoperative scan, we'll now get real quick information. It took me a minute to do the scan in the operating room, and it gave me really good feedback on a young 25-year-old boy that I did recently with a deep insular tumor. And then I think this is the final slide, or the next slide is the final slide, just showing when I did the second article in the Journal of Neurosurgery, which came out last month, and we looked at the ability to determine how much tumor we're taking out by zone, we get a pretty good estimation now where I can go to the patient, and when they say, how much tumor can you take out? And I say, well, you have a zone 3 tumor, and this is how much tumor I can take out. As long as I know that it's worth doing that, meaning once I get much above 50% resection, that's when I make an impact. And so that's worth doing. So whether it's in the insula or in the frontal lobe or in the temporal lobe, no matter how big it is, it really doesn't matter, because the bottom line is you have to be aggressive. We have to take out as much tumor as we can. We know that impacts outcome, and we got to do it safely. And if we can do all that, then that's the best thing for the patients to do, and it's worth it. I don't care if I have to spend 24 hours in the OR, I'll do it every day if I can help somebody out and not hurt them. So that's the key. Okay. So